Everybody, welcome to the 2024 National HPV Vaccination Roundtable National Meeting. I had to double check my video because I was definitely doing some chair dancing to that intro music. So I hope all of you were too. Really excited for today. I'm Dr. Kristen Oliver. I represent the American Academy of Pediatrics on the Roundtable Steering Committee. Really excited for all of you joining today. I hope you are able to tune in this week and enjoy the first 3 sessions. I was able to catch yesterday's session, and it was just great to hear about all the energy and the work happening among dentists, pharmacists, and school nurses to help raise awareness, acceptance, and access to HPV vaccination. Now, today, we're going to get our party hats on and prepare to be inspired by the work that we've accomplished in partnership with all of you over the last 10 years, and to gather new ideas on how we can accomplish and continue to innovate together to prevent HPV-related cancers. But first, housekeeping items. So 1, throughout the session today, please post your comments, reactions, anything you might need into the chat box. I think it is really fun to see when people react to things that are happening with ideas or excitement about what they're hearing during the talk. So please do that in the chat. A special shout out to Amy Pisani, who I think has been really active in the chat in the sessions I've been in, and I love seeing that. So thank you. But if you have specific questions for the speakers, ideally post those in the Q&A box. It's easier for the people who are moderating to see the questions there and then pose them to the speaker. So use the Q&A box for specific questions for the speakers. The presentations and a recording of today's sessions will be shared. So please do subscribe to our newsletter via the website and follow our socials for more information on new resources, videos, and more. Before we dive into today's session, I want to thank everyone for joining and everyone that's helped us to build all of this work over the past 10 years. This really is a celebration for all of us, hence the party music. Today, we're going to explore the world of HPV vaccination partnerships and collaborations. We're starting with the celebration of the 10 years of the ACS HPV Vaccination Roundtable by hearing from Dr. Margot Savoy. Then you'll hear from 2 different HPV vaccination partnership and collaboration projects. And you'll have an opportunity for questions with the panel following those presentations. And then finally, it would not be a roundtable event without a call to action. And during our after party to end the celebration today, we'll be talking about that. Recently, I had the real pleasure of spending some quality time with Dr. Margot Savoy to help celebrate the 10 years of the ACS HPV Vaccination Roundtable. She was one of the original steering committee members of the roundtable, and I was able to interview her. Let's watch that now. Hi, everybody. I'm Kristen Oliver, a pediatrician and preventive medicine physician at Mount Sinai in New York, and I'm very excited to interview Dr. Margot Savoy, a family physician with the American Academy of Family Physicians. So good to see you again.
Good to see you too.
Great. I want to start out because you were also one of the inaugural members of the HPV Steering Committee, but we want to have you give a chance to let everybody know what your current work is and how you bring your passion into that work.
Oh, thank you so much. So it's funny, like when they said 10 years, I was like, 10 years? We just started this work yesterday. But it turns out we've been doing this for a long time. So I'm excited because I happen to have an awesome job. And so even though I don't get to do as much of the HPV roundtable work officially today, it's because I got a job where I get to do HPV roundtable secret work behind the scenes all the time. So in my day job now, I'm in charge of education, inclusiveness, and physician well-being for the American Academy of Family Physicians. And so it means that I actually get to help design and set up the topics that we talk about in family medicine about continuing medical education in our undergraduate and graduate medical education spaces, amongst other things like helping oversee our journals and our diversity and equity and inclusion work. And what's fun about that is that HPV vaccination shows up in all those places. So when you think about the things that we can do to help make sure that people have what they need, cancer prevention, making sure that people have access to information, knowing about immunizations and vaccination, thinking about good, solid public health practices, making sure that family physicians are prepared to have those conversations, making sure that patients have the right information so they can make the best decision as they try to have those shared decision-making conversations with their doctor. All of that stuff with the little bow of making sure that we're being thoughtful and how we're being empathetic and inclusive in our listening and able to hear and relate to the patients is all the work I get to do every day. So for me, it's like the perfect sort of combination of all the ways that I get to leverage that work. And then I just get to sneak in HPV as examples every chance I get about how that's one place where we really have some great opportunities and some really strong messaging. Like it's not, you don't have to wonder, like it's really clear what the task is and what we're here to do. And it makes it very easy to be able to make that the example and help people understand how they can do better, particularly those of us who have a strong interest in prevention.
Thank you. And you can tell whenever I speak to you, I'm always frankly sort of looking you out so I can sit next to you at lunches at conferences. But part of that is because of the great passion that you bring to this work. Can you tell everyone a little bit how that, like where that comes from and how it helps push you forward?
Oh, I would love to. So I mean, the interesting part of my story, I think, is that I don't know that I actually cared about HPV vaccine at the beginning. It wasn't something that was on my radar. I'm not even sure I particularly cared about vaccination at the very beginning. What happened for me is that as a family physician, you spend a lot of time counseling patients on the other side of bad things happening. And so you're watching people who you love and care about and you're taking care of have issues and problems. And when you start to really think about how you could prevent it, the things that you could do that truly have an impact on preventing them from ever getting to those hard conversations, turns out vaccines are like the number one thing. So just as a group of things to do, vaccines continuously come up as being the number one thing that you can do to prevent issues for folks, right? And so I was like, oh, let me learn more about vaccines. And in learning more about vaccines, I had an opportunity to do a vaccine science fellowship with the AAFP. And in doing the vaccine science fellowship, I got to spend time with a bunch of different organizations that the AAFP was working with to try to figure out how to get messaging out. One of those groups happened to be the American Cancer Society, and then they were going to be having this roundtable starting, and they were like, we need someone who understands vaccines, but who also really spends a lot of time with sort of adolescent teenager age group in their practice, and that was part of what my practice is. And so I'm like, oh, well, that's me. I do that. And they're like, we've got this HPV vaccine. I'm like, why do people care about HPV? Doesn't everybody have HPV already anyway? Like, why does that matter? And people started describing then, because back then we weren't sure if it was going to truly prevent cancer. We just knew that it might. We didn't have the data yet to say that it would. And they were like, we're pretty sure it's going to be able to prevent cancer. And even if it doesn't completely prevent cancer, we think it's going to prevent a lot of those cervical lesions where people have to get colposcopies and then it causes issues with their cervix later. And I'm like, so there may be a time where people don't have issues where they're having to have all those cerclages put in because they had to have multiple biopsies, and we don't have to scare them with like abnormal pap smear results because we might just prevent it. And they were like, yes, sign me up. Like I'm in, because that's a really scary time for people who have a uterus and people who have a cervix. Like, I mean, it's a really scary thing to hear that your pap smear is abnormal, or there may be something wrong, or that you may not be able to have children, or to being unable to bear your pregnancy because you really have had to have damage done to remove precancerous lesions. The idea that you could just prevent that, just not have it happen at all, and it's just by having a vaccine, just seems so remarkable to me. And here we are now, years later, and it truly is a cancer preventing vaccine that we have available to us. And so I'm really blessed and honored that I got, sort of tapped without having a lot of knowledge about it ahead of time. And it feels like a really great honor to be able to spend a lot of my career now telling people, so they can go on to be able to share that message and make sure that people understand. Because I was just ignorant about it in the beginning. It really wasn't on my radar.
I doubt you were ever really ignorant, but I also just wanted, like, for everyone who's been involved with the roundtable, and what a pleasure it was to work with you too. And I wasn't there in the very beginning, so I came in later, and so I've always been very fortunate to get to learn from you. But take us back to 10 years at the beginning and your time on the steering committee. What was that sort of like? The collaboration, the excitement, I assume.
I mean, it was interesting. I mean, so like I say, it was the first time I ever did anything like that. And so for me as a relatively young clinician, I was amazed because I had always thought about partnerships where people come together as sort of being the doctor is the center and everybody else is sort of working with the doctor, and we're going to tell everybody what to do. They're going to do what we ask them to do, and then we're all going to move on. And it was one of the first times I got to see in a really large national way how having a multifaceted group who brings lots of different thoughts, how patients can be activated to be a voice and to be able to speak for themselves and to help us design things that make sense for them, how you can really help different groups of the bigger sort of neighborhood be prepared and ready to amplify the message, but also feel comfortable with the message because they helped design it. It was amazing. I mean, it genuinely was amazing. Now, I will tell you, for me, it was a bit scary. So, I mean, there were times where I wasn't really sure how we were going to get over some of the hurdles. They seemed so big. It seemed like people had so many issues with the vaccine. Back then, it felt like, people had a lot of weird narratives about immunization and about that particular vaccine. And it was just interesting to think about, well, how are you going to overcome that? Like, if everyone's already having these feelings and having these thoughts, what are we going to do? And then we knew the science was still coming out. And you're like, well, what happens if the science comes out and it's a problem? And what are we going to do? And for me, that was exciting, but it was also kind of scary. But what I loved about it was the camaraderie. Like, so every time you got together with people, you just felt energized and passionate, and you realized and remembered, particularly like, I mean, it was one of the very first times I've had an opportunity to work with advocacy groups that were patients who have been affected or have had a lived experience that really plays into what we're talking about, get a chance to come and speak their story. And I mean, I think you might have someone interviewing Tamika at some point, but Tamika changed my life. Listening to her tell her story, A, brought me to tears, B, made me so incredibly, amazingly proud of her. And then I thought about all of my patients who have probably had similar stories to her, that I never had the time to hear that whole story. Like, I heard a side of the story, but I never got to hear the whole story and the impact and the power that a person could bring. I mean, it literally changed my life. I mean, it really changed the way I approach how we include patients in the work that we do and how we think about the bigger narrative. And like, in something that seems so simple, like a vaccine, you wouldn't think you need that many people to come together to think about how to strategize and make it make sense. And yet it does. I mean, it really does make a lot of sense, and it makes the whole thing more powerful. And it's because it's just that important.
Thank you. No, I think about that a lot with the patient stories too, especially as a pediatrician. I never see the patients when they're actually going through the cancer that they get later on. So those stories are so impactful as well. You did mention something about a hurdles around HPV vaccination. So I want to get back to that. If you could think back, what is sort of the biggest hurdle that was faced in the first 10 years, and how the roundtable and just the HPV vaccine community in general overcame that?
So I think the biggest hurdle is probably still the hurdle, although I'm not sure. Sometimes I feel like it gets shorter and then somebody comes back and like props it back up again. But it's literally misinformation. So people's inability to be able to sort out, particularly in that social media space where it feels like everyone has an equal voice, but everyone's not always being equally honest with you, with their intentions about why they're saying what they're saying, or the evidence that they're using to speak what they perceive to be their truth. It feels so frustrating when you think about the fact that there's real evidence and real science. And at one point, it was just annoying. Like, it was just sort of a, gosh, that's really irritating. You're saying things that's kind of goofy, that's silly, please stop. But now I feel like we've gotten to the part where it's actually causing people to make decisions that are potentially costing people their lives. And so we've gotten to the place where not only have you made people question, which I think is actually really important, and I think it's a great use of social media. So asking questions, making sure that you have the information you need to have about the safety, the efficacy, the things that you want to know, how you're getting the vaccine, what are the side effects you expect, all of that, I actually think is amazing and wonderful. And I love the community coming together to ask us the right questions and to challenge us to do the science well, and to make sure that we're reporting it back. Like, I think that's 100% right. And we have to be accountable to society for that. What I don't like is the people who seem to be spreading messages. I don't know if they just get joy out of it. I'm not really sure what they think they're doing, but they're dismantling a level of trust that is causing patients to choose to make decisions that ultimately allow them to be opened up to things like cancer. And I just can't imagine why anybody would want to do that. And it just feels like such a big hurdle. What I feel positive about, though, and the reason that I don't just get bummed out entirely and sort of just give up, is because I'm starting to notice that it's not just the medical community that's getting frustrated about it now. I'm seeing where our ability to help other people in the general community realize that these people are doing things that are harming all of us, and that they too have a voice and their voice is important. And that even though it seems like a common sense thing, like, well, no, I don't need to talk about it because of course my kid got their vaccine. Like, I get all my kids on my vaccines. This is not a news story. But your silence sometimes is actually challenging because your silence lets them have even more airspace. And so people are starting to speak up and talk. And so you're using the tool back in the other way. And for me, that's sort of the hurdle turned on its head. And so I see there's sort of the transition where we have this opportunity to start really letting people use their voices, but being the voice for the good side of it. So the challenging and the thoughtful and the really true shared decision making, and thinking about what's right for you and your family, and making a decision based on good, solid evidence so that you can do what you need to do for you and your family. but drowning out the voices of the people who are sort of spouting misinformation or being just, disingenuous in what they're sharing with people. So that, to me, that was the biggest hurdle back then. I feel like in some ways it's a little bit bigger, but I see it. I just see people talking and having conversations and sort of shooting down the things that are just inaccurate. It makes me really proud of us, because I think that's where you're gonna have to take it back. You got to take back your health and take back your voice and make sure that people are getting what they need. And I think we can do that together. It doesn't need to be doctors taking it for you. It's everybody getting to take it back for everybody, because this is a society issue, not just a medical issue.
Absolutely. I love the way that you're able to frame that in a positive light. I think it's so important. We all get, I think sometimes get just so bogged down with the idea that we can't dig ourselves out of this sort of misinformation social media hole. But I think pointing to the fact that everyone is coming around is going to try to help. I heard an interesting phrase the other day that if we want vaccines to keep protecting us, we have to protect vaccines. Right. And I think
Yes, that's
everybody's
such a good way.
not mine, I know, but really great. Right. So I think I like that framing. Along those same lines, what do you think are sort of some of the best opportunities to sort of increase vaccination for HPV in the US? And one of the big roundtable things that we always like to do is a call to action. And so what would your call to action be to everyone who's listening to this?
So my biggest call to action is kind of the same, regardless of whether you're a clinician or whether you're a patient or you consider yourself a patient in this situation, because sometimes we forget that clinicians are also patients too. But regardless of where you are in this spectrum, my biggest call to action is, if you're not sure, talk about it. Because if you're not sure, you need to ask the question. So I don't want you out here making assumptions about what you think is right. If you think it's the right age, or you're not sure you're the right age, or you're not sure about the right dose, or you're not sure about the right number, you're not sure if your staff is able to do it, you're not sure if you can get paid for it, you're not sure if your insurance will cover it. There's a million questions that could come up around this vaccine, around vaccines in general, around HPV, the disease itself, and about what those cancers are and how that could affect you or not affect you in your life. And rather than not ask the question and be afraid that somehow asking the question is going to be a problem, I would love it if all of us just had the conversation. The more that we talk about it, the more that we can dispel the myths, the more that we can get you the information we need. And if it turns out that you asked the question that we haven't considered yet, we can go get that answer and we can find out something new and make sure everybody has the things they need. And so my biggest call to action is to continue the conversation. So we're not done. So I know a lot of people have been vaccinated. It feels like it's kind of a routine vaccine. It feels less sexy. We had some other things happen, like a pandemic, and everybody got focused on that. But like, the conversation's not over. The discussion's not done. We still have work to do. And so continue the conversations, continue them with your family members, continue them with your friends. And honestly, stop and pause, think, do I know all the things I need to know? Should I go find out something new? And really spend some time making sure that you're staying educated and up to date on all the things that are going on. So that would be my call to action. So just keep the conversation going. We should keep talking about it.
Thank you. And we know we will keep talking about it. I love that you're finding out something new, because there is like always new great information about there and how effective the HPV vaccine is. And we do love sharing that as well. And thank you so much. And I think it might be nice for everybody to sort of get to know Dr. Savoy a little bit better. So we're going to do some lightning round fun fact type questions. Are you ready?
I'm
All
down.
right. So, and when you're not reading manuscripts about HPV vaccine, tell me, what do you like to read for fun?
Oh my gosh. So I tend to be a person who has a book on Audible teed up at all times. My favorite go-tos though are usually some version of a horror book or a romance. Somewhere in there, there's a mystery. And so usually I'm listening to Stephen King or Agatha Christie, but I'll throw in a romance every now and again.
Or a horror romance, for instance.
A horror romance is my favorite.
I don't know how you sleep at night. Similar along those lines, what keeps you sane and what brings you joy?
Oh, so like, some people might question whether or not I'm actually still sane, but the joy part is really kind of nice. So I am terrible at remembering to carve out time for me. Like, I tend to be a person who needs a schedule. And so way back in the day when I was a resident, I got taught that one way to do this is to actually book time for yourself, or book time for you and a partner if you have a partner, But you have to, for some of us, you have to put it on your calendar because it's really hard for you to break a date with yourself or with somebody else if it's on your calendar. For other people, this is apparently is not a thing. I'm not the queen of spontaneity. And so way back then, I started booking time to do things. And so at this point, I'm up to 3 sets of season tickets to help me book time to make sure I do things. My absolute newest one and my favorite one is my Ravens tickets because I love the Baltimore Ravens. So that has me joyful. People think that's weird because my second one is opera, which I've had since I was a resident. And so I've got season tickets to the opera, and then I've got season tickets to musicals, which people are like, well, you've already seen the music in the opera. And I'm like, musicals and opera are not the same thing. And so it's just really kind
No.
of cool to have all those different things. And then I get to go with different people depending on what's going on. And so I get to see friends and family, but I also get to do stuff I like and love. And it brings me joy. And so it's just a nice way to do it. But I had to schedule it because I don't do the spontaneity thing very well.
No, you're really sort of motivating me to think about something like this. I should sign up. But now I have to ask, what's your favorite musical?
Oh gosh. So my favorite one is also weirdly enough the one that I only recently just saw because I knew the music. I was in band in high school, so we played a lot of musicals. It's Les Mis. Like I love it, and I finally got to see it in person, and they had me sitting there crying the whole time like a big baby. But I absolutely loved it, and I enjoyed it so much, and it's coming back again. And I'm like, you don't have to go again. You don't have to go again. I'll probably go again.
But you do. Yeah, absolutely. Oh, good. And finally,
I
what's
will
your
give you a shout out though. So for those of you who haven't seen it yet, Hades Town is amazing. It
Oh,
was
yeah.
that was another one that was just, I mean, it's newer, so people don't think about it as much. Oh my gosh, it was so great.
All right, now we have our full schedule full. Thank you. And finally, what's your favorite cheesy joke or dad joke?
Oh, I love a dad joke. So my absolute favorite, it's the one that I get excited about pretty much like every couple weeks. My bestie will come in with his new haircut and I'll be like, oh my gosh, you got a haircut. Because I get excited because he got a haircut. And he goes, no, I got them all cut. And then I cannot stop laughing the whole rest of the day because I'm like, they're all cut.
Classic. Very good. Thank you so much. Let's not wait 10 years to have this conversation again. It was good to see you. And thanks
Thank
everybody
you.
for watching and listening. And thanks for all your work. All right. I hope you enjoyed hearing that as much as I love talking to Dr. Savoy. All right. As a New Yorker who knows that New York is much more than just New York City, I'm excited to introduce our first panel today for a look into collaborations and partnerships with my dear colleague, Michael Sesserman from the American Cancer Society on taking action on HPV vaccination in New York State. Then we will have a Q&A panel with some of the partners who made this work possible. And happen Dr. Monica Surya-Devara with SUNY Upstate Medical University and Annalia Trask with Stony Brook Cancer Center. Welcome, Michael. Good to see you.
Thank you, Kristen. Good to see you. Well, good afternoon, everyone, and thank you for being here today. I mean, collaboration is something that definitely energizes me, and we've had a great collaboration in New York, so I'm excited to share this with you. So, next slide. So the New York State HPV Coalition was created in 2017 as an action team of the New York State Cancer Consortium, which is New York's Comprehensive Cancer Control Coalition. And so as a team, we came together and we chose the mission to increase HPV vaccination rates and decrease HPV-related cancers in New York State through education, coordination, advocacy, and leadership. Next. And so as you can see, we have quite a robust steering committee with 17 different members representing the medical specialty groups that are relevant to HPV, the major medical centers, the New York State and the New York City departments of health, the cancer center. So we really have, quite a collaborative bunch that really got our steering committee, or the coalition, I should say, going. And currently it's more of an ad hoc committee, but for quite a while we were meeting as a monthly to get the coalition going. Next. So this is from our latest action plan where we developed a couple different goals, but our main goal relates to on-time HPV vaccination, which is to increase HPV vaccine series completion rates to 45% among 13-year-old adolescents in New York State by 2026. And you can see that our baseline was under 40%. So work to do for sure. So going back to 2018, which is amazing that, the coalition has been working for about 7 years now. But in our first year, our priorities really were to do like an assessment, and team and coalition building planning and find some funding. And so to do that, we developed an environmental scan, kind of looking in New York State to find out, who was doing what around HPV vaccination so we could collaborate and do it together and build on what's been already done. And the state health department really led that effort. We did a SWOT analysis among the leadership. We then created a logo and launched our website. We recruited general members, and we have well over 300 at this point. We applied for funding, and we developed our 5-year action plan. So that was a busy year. Next. So this was our early organizational structure as a coalition, where our steering committee, of course, on top, and then we broke into provider education group that focuses on working with vaccinating providers and health systems, and then public education, obviously working more with non-vaccinators and the school environment. Under provider education, we eventually created an HPV health plan work group that lives on to this day. Next. And this is just an image of our from our website, and people can sign up as general members through the website. Next. So for our priorities for year 2 and 3, we focused on funding and intensifying our education efforts, working with large health systems, and promoting evidence-based interventions, which I'll talk about in the following slides. But we did get that grant that we were shooting for from the New York State Health Foundation, and that really funded us for a while. Next. So I'll walk through some of our interventions. So this was our HPV vaccination QI training initiative, which was led by Dr. Monica Sariadevara from SUNY Upstate Medical University. And you can see her back there in the corner with her providers from one of her cohorts. Next slide. But they would do training and provide technical assistance during the time that this was going on. It was a 2-year period, but Monica can give you the details, but they went on for several months each during each of the cohorts. But the results were providers and staff from 52 pediatric and family medicine practices participated in our QI training project. The practices completed data entry, review, and discussion, and there were increases in aggregate vaccine series completion rates of 10% and reductions in aggregate missed opportunities to vaccinate of 9%. A number of system changes were implemented during this period, which included standing orders, review of immunization record at each visit, earlier discussion of the vaccine series, meaning starting at age 9 or 10, stronger recommendation for HPV vaccine, which was a major focus of our first few years of the coalition. And you can see some of the others there. then in June of 2020, we had a CME webinar, which we attracted about 150 people to that one. So we were pleased with that engagement of providers. Now, on the public education side of things, we, like I said, we were engaging the school environment a little bit, and primarily through our work with school-based health centers. And so Dr. Yana Shah, also at SUNY Upstate Medical University, and also an infectious disease pediatrician, leads this group, and we work together on creating this guide for school-based health centers on HPV. She went on to do a learning collaborative with school-based health center providers. We tabled and presented at 3 different statewide conferences. And you can actually access this guide through the National HPV Vaccination Roundtable's resource library. Next. Moving on to our work with our health plans in New York. Early on, we were working collaboratively on certain interventions, and this was one where we had a co-branded letter that went out to providers from both the health plans and the state and city health departments and ACS, just encouraging them to provide a strong presumptive recommendation to parents about the HPV vaccination. And so that went quite well and reached quite a few providers in the state. So over time, our health plan work group evolved into a learning collaborative. And now it's currently focused on our Medicaid's HPV Performance Improvement Project, or PIP. And so the state's requiring all of the Medicaid managed care plans to implement quality improvement projects for 2 years focused on HPV vaccination. So we're excited about that. We've done 3 rounds of New York State HPV Vaccination Honor Roll Awards, and provided 72 awards to date to high-performing providers, just to recognize their efforts. Next. We did a digital HPV vaccination advertising campaign in 2020. Next.
Kids dream big. Keep
You
them
can go
healthy,
on.
and nothing.
Thank you. And then we collaborated with the dental setting and first the Dental Hygienists Association, where we trained 38 dental hygienists. We actually have an event coming up with them next month. Once again, we've collaborated with the New York State Dental Association, which continues. They're an active member of our coalition, and so we've done CE webinars in the past with them, and they're available on their website for ongoing use. And then we did a dental pilot with 4 different FQHCs, which where we were trying to get FQHCs to do warm transfers to their primary care when they identify a child or young adult who has not been vaccinated for HPV yet. Some of those findings were included in a recent paper as well. Next. So on to our current action plan, 2023 to 2026. We have improved communications by adding a monthly newsletter, and my colleague Julianne Roman leads that effort. We have collected data in low-vax counties, and we recently just released or had a paper published on that, and that is really informing our efforts to work in those low-vax communities. I'll talk about starting our Start at Age 9 campaign in a moment, as well as our summit. But we created a new HPV Health Equity Action Team, or HEAT, which you can go on to the next. Okay, and so this is our structure, where you can see we've added the HEAT there, and we added a college work group, which Anna Leah leads, along with Martha Ryan. Next. So our Start at 9 HPV vaccination campaign was very successful. We had 59 health organizations endorse starting at age 9, including the state health department and these other organizations you see here. Also, our state's IQIP program, which all the local health departments implement, have added starting at age 9 as a recommended policy change. And we are discussing with the state and city immunization registries to reflect the SA starting at 9 endorsement in their forecasting in their registry. So more to come on that. And all of those 59 partners sent out that provider letter that I was showing there. We also did the summit in April. You can go on to the next slide, where we featured breakout sessions for providers, as well as community-focused partners. And we also focused on HPV vaccination education and about what are the most effective policies to increase HPV vaccination. Next. So our new activities from our current action plan are with the HPV vaccination college group focusing, they did a survey, and now they are implementing a toolkit with the different colleges. So, and Aaliyah could speak more to that. Maintenance of certification project for pediatric and family docs. So Dr. Monica can speak to that. She'll be taking the lead there. And then our new practice outreach project, which we're gearing up for, which will be a peer-to-peer promotion of best practices in low vax areas. So that's like pediatricians talking to other pediatricians, for example, about how they can boost their rates. So more to come on that. And then we're just launching the faith community work group. So here you can see, this is looking at HPV vaccination up-to-date coverage for adolescents ages 13 to 15. The black line is New York City, the yellow is New York State, and the blue is the country. So you can see we're all on an upward trajectory except for last year, and so hopefully that will continue. So that's all I have, and I look forward to answering any questions you have along with my partners.
Thank you, Michael. I'm Lisa Robertson, the Executive Director of the Indiana Immunization Coalition, which has been around for 21 years, and I've been in my role for the past 11, so I understand the true importance of partnerships, so I'm excited to hear more from you all about the work you've been doing. I'd like to welcome Dr. Monica Surya Devara and Anna-Leah Trask alongside Michael for our Q&A. So first I'll start maybe with maybe Anna-Leah. I know you're doing some work in equity, but what strategies or best practices do you utilize to establish partnerships and relationships for your work?
Yeah, so thank you so much. Hi, everyone. My name is Anna-Leah Trask, and I do this work on behalf of a grant in New York State called Cancer Prevention and Action, and we are supported with funds from Health Research, Inc. and New York State. We're all about building community and partnerships. And I think, especially in the space of HPV vaccination, as well as our work, my work with the collegiate health group for the coalition, yeah, building these partnerships and collaboration is so important. It allows us, those of us who are working towards the same goal, increasing HPV vaccinations, to work together towards that shared goal. So this allows us to utilize and work off of each other's strengths, skill sets, and resources. You know, those may have not been available to you when you were working individually towards that particular goal. You know, we know that HPV vaccination uptake is so multifaceted. There's so many influencing factors. Just looking at the 5 A's, for example, a lot of us are familiar with that concept of the access, affordability, awareness, acceptance, and activation. And we know that all 5 are important to be addressed when we're looking at HPV vaccination. So if I'm working towards awareness, for example, but maybe I don't have any resources addressing that access and affordability, maybe that's a barrier in my community. So I can lean on those partnerships and collaborators who may have those resources. And I can in turn provide, you know, the resources that I have at my disposal. Maybe I can refer to others in my organization, in my health system, or through the resources of the grant program. But maybe then acceptance is still a barrier in our community, right? So we can again turn to our partners, address this together, lean on each other for those resources. And if we don't have those resources, we can do that work together, making that that workload a little lighter on all and allowing us to get more done.
Perfect. Thank you. And Dr. Monica, I mean, a 10% increase in vaccination rates and a 9% reduction in missed opportunities. Congratulations. That's a really amazing work. And I know to do that, you had to have great partnerships. So do you want to add anything to Annalia's comments about how, you know, what strategies and best practices you use to form those partnerships?
Yeah, I agree with everything that Analia spoke about in regards to building these partnerships. Most of the work with the change in immunization rates was really building partnerships with practices, and it's very important in order to be successful is to get everyone in the practice on board and build a relationship with everyone from, you know, the front desk staff to the providers to the office administrators. Really educating everyone on the importance of HPV vaccine, letting everyone have input in onto evidence-based strategies that would work for their practice, really helped in getting practice buy-in, provider buy-in, sustainable changes that you can then see positive results from that are long-lasting.
Perfect. Thank you. Michael, did you have anything you wanted to add before I move on to the next question?
No, why don't you go ahead?
Okay, so what action steps would you, could a state wanting to get started on an HPV project take? So what would your steps be if they wanted to get started on an HPV project?
Well, I can certainly speak to that. I'm actually going through that process now in New Jersey, sort of replicating what we did in New York. And for me, it's working closely with the State Cancer Coalition and the State Health Department, and together identifying supportive partners. You know, one of the things that was really helpful was that environmental scan process. And this is actually, I think there's a nice resource that the roundtable has in doing these environmental scans, but it kind of helps identify who is working in this space, so you can bring them into a state coalition of this kind. And then, you know, you work together to develop the team and develop the plan and go from there.
That's wonderful. It sounds like a lot of work. So, and it's going to take a couple of years, I think, to kind of see the fruits of all of that labor. And I know how long and consistent these partnerships have to be. So congratulations on the work in New York and New Jersey now. So moving along, what do you feel is the value in collaboration and partnerships to advance HPV vaccinations specifically? And maybe Dr. Monica, you can address that since you've been doing so much to increase immunization rates.
Yeah, I can start and hear what Michael and Analia also have to contribute, but I would say one of the most important for me, the most important value from being in the coalition is being able to not have to reinvent the wheel, to be able to use resources across the state, to work with people who are already trying to do the same thing, and then an increase in reach. A lot of our messaging and a lot of our quality improvement projects have had a larger reach just because we have involved so many different organizations across the state on our regularly scheduled calls. We get to hear what other groups are doing, so then you can have further collaboration that way. You can, borrow resources, borrow tools to make what the work that individuals are doing more of a larger scale.
Perfect. As a nonprofit, we love borrowing things. That's a great way to reduce the amount of resources we have to put into a project. So I will be looking at your sites to see if there's anything to borrow for Indiana. But Analia, do you have some things you'd like to add about the value of partnerships in advancing HPV vaccination?
So I think that Dr. Monica Davera, sorry, has said it really well. Really increasing that reach, really increasing those partnerships that allow us to do this work, and working harder and not smarter and not harder. I think really there are strength in numbers as well as strength in community. And with that strength, we can really take action on our projects and make a difference in our state. And that becomes pretty easy once we have that community together.
Thank you. We have a question from our participants. So how did you identify the practices with 80% vaccination rates so you could give them their awards?
Okay, so that was really done through a collaboration with the state health department in accessing their what we call in New York State NICIS, for outside of New York City is the registry. And so, each actually with that's a statewide program. So we were getting data from both the city registries and the state registry, and then they would identify the providers that met the criteria. And so we had most improved we broke the state up into 10 different regions and had most improved awards, and then 2 different state awards for high honors and honors. High honors is greater than 90%, and I think there was like just one provider the last couple of times, and then honors, which was greater than 80%.
Wow. I mean, that's still remarkable. 80, 90% HPV vaccination rate is phenomenal, and wonderful partnership working with the state to get that data, right? Because data helps us tell the stories and recognize those people doing amazing work. So one of the other questions is about challenges around starting at age 9 campaign, like how that was received, if you heard any positive, negative feedback, or what your providers thought about the age 9 campaign.
Yeah. Monica, you could probably speak to that. You did a lot of presentations to providers and others.
Yeah, so I would say of all the HPV presentations I have done over the years, the Start at 9 was probably the most well received. I am working with practices currently in the Syracuse area to start at 9 and trying to determine the impact that starting at 9 has on vaccination rates by 13. And even anecdotally, providers are saying that it's been easier for them to recommend vaccine. The conversations are easier. There seems to be less pushback. So the experience that I personally have had has been very positive with the Start at 9-10, with the understanding that we still need to, collect long-term data to see how that makes a difference on the overall HPV vaccination rates among this population.
Wonderful. Analia, did you have anything to add about the age 9 campaign?
Yeah, so I didn't have as much direct involvement as Michael and Monica, but you know, seeing the campaign unfold, one thing I noticed is that those endorsements that Michael spoke about in the health systems and many organizations that signed on to it, at the beginning, it was a little slower moving. And once we got a few of the big players on there, right? You know, the AAP, you know, the New York State and New York City health departments were big ones. We started to see them all really coming in quickly, and people were more on board. And I think that really speaks to the power of those collaborations and those partnerships. Those health systems, those health organizations, and the leadership within them showing that this is an important issue. They were willing to take the time to sign on, send that letter out to their providers, really spoke volumes to the importance of starting at 9 campaign and HPV vaccination and cancer prevention as a whole.
Thank you. That's amazing. Those partnerships are wonderful, and I'm sure have really given you more of a voice in New York. Michael, did you want to add anything before we have some closing thoughts?
You know, I was thrilled with all the collaboration on Start at 9, and you know, some organizations it took a while to get them on board, but you know, I was very pleased with the number of organizations that endorsed and sent out provider memos encouraging them to get on board with that as a clinical practice. And you know, it seems to be just a great intervention for bringing a whole coalition together. It wasn't just certainly us three working on it. It was, you know, all across the coalition, folks were involved. So that was one thing I really loved about it, and just the potential impact we can have. So I'm looking forward to seeing the results.
Wonderful. So just one last quick thought from each of you. Moving forward, what is the one kind of project or partnership that you're most excited about in this coming year? I'll start with Michael.
Okay, well, I spoke about it briefly, and I think it's the practice outreach project, and I'll be working with Monica and our other clinical champions on that to make that happen, because it will really take pediatricians, family docs, nurse practitioners being willing to, you know, help us knock on those doors at practices in low vaccination counties. It's going to take collaboration from the city and state registries to get the data we need to find those low performing providers. It'll take working with local health departments who have a lot of that data and already know some of those providers, because they're working with them on their IQIP program, where they're trying to do quality improvement with the low performing providers. And so we see this being complementing what they're already doing with IQIP. And so we'll see how that goes, but I'm excited about the potential, because, you know, we can do all the webinars we want, but it's not necessarily reaching those providers that are the lower performing providers.
Right, that sounds wonderful. Hopefully I'll hear about it on one of these webinars next year. Analia, what about you? What are you most excited about in this upcoming year?
Yeah, so as Michael mentioned, one of my primary roles in the coalition is co-chairing the collegiate health work group, and our mission there is to support HPV vaccine increases in the college health space. So we're focused really on those 18 to 26-year-olds, or rather maybe the 18 to 22-year-olds, that really undergraduate age. Empowering the young adults who may not have had any ownership of their healthcare decisions before that age, to learn about the vaccine and its importance, and B, you know, actually motivate them to take action to get vaccinated and complete the series. Here in New York, about a third of adolescents have not been fully vaccinated by age 17. And there's unfortunately not a lot of reliable data beyond that going into the adult years, but we can use that as a starting point, right? That's a third that we're here to empower them to get vaccinated. So we have a lot of really cool projects going on in that space. The work group has really become a collaborative effort between those of us in the public health space, those of us with some of those vaccine resources, such as some of the mobile vans and clinics that go onto the road and provide vaccinations and go to the college campuses, and then those in the college space, so college health center directors, professors, and even some students have come on board and are taking action. So working together to really get students vaccinated. It's not enough to have them be aware. We want to actually get, shots in arms. So we're working on some cool stuff, and we're really excited to move forward.
That's a fun group to work with. I love the focus on the young adults and kind of helping them take control of their health and kind of talking to them about what they might have missed as an adolescent. So that's really great work. And we will give the last word to Dr. Monica on what are you most excited about this coming year?
So I'm going to have to echo Michael's provider outreach program for a couple of reasons. The biggest reason being that over the past few years, we have focused on, general campaigns. Let's get the word out there, educate providers, educate communities. But this is our opportunity to find areas where there are low vaccine uptake, try to figure out why, what we can do. And I'm hoping this is a way for us to make very significant change by doing targeted interventions like this provider outreach program. And I'm hoping that since we were able to get this program some MOC4 credit, which is QI credit for providers who need to maintain certification, it will be an incentive to increase engagement with our providers. But I'm excited to see the change that we can make over this coming year.
Well, thank you all so much. That's really fantastic work, and I'm excited to continue to hear what you're doing in New York. So thank you to all of our panelists for encouraging state partnerships and giving us a look into how you can get started and the impact of collaborating to increase HPV vaccination rates in your state. So thank you all.
Thank you.
Next up, I'd like to introduce our next collaborations and partnerships presenter, Dr. Heather Brandt with St. Jude Children's Research Hospital, is looking at a national focus to increase rural HPV vaccination. And then we'll have a Q&A panel with 3 of the partners that are collaborating to bring focus to rural communities. Dr. Brandt will be joined by Ashley Lack with the American Cancer Society and Sarah Lawley with the American Academy of Pediatrics. Welcome, Dr. Brandt.
Thank you so much, Lisa. I'm so excited to have the opportunity to share some information with you about our work in rural communities. And so I hope you were able to join us yesterday for the excellent presentation from Dr. Jennifer Irves about inequities in HPV vaccination and the really great discussions we had about addressing inequities in HPV vaccination and HPV cancer prevention among populations that are under-vaccinated. And rural communities are part of this under-vaccinated group as well. And 1 in 5, or about 20% of the people who live in the US choose to live in rural communities. So this is not a small group. And in simplest terms, the reason for our focus at St. Jude and the focus of these many national partners on improving rural HPV vaccination is because those who live in rural areas of the US have higher rates of HPV cancers and lower rates of HPV vaccination. And rural doesn't mean one size fits all. Rural communities are not monoliths, and rural communities possess many strengths in addition to noted challenges affecting their health and well-being. So HPV cancer prevention is for people living in rural communities too. Next slide. And so perhaps you have an idea of what someone who lives in a rural community looks like. Rural communities are highly heterogeneous, and they reflect the vast diversity of people who make up our country. And people who live in rural areas also are not only checking one box at one time. they may simultaneously experience advantage and disadvantage. And so our approaches to improve rural HPV vaccination cannot be singular in focus, and they must account for and embrace these differences. And earlier you heard Michael and the excellent group from New York working on HPV vaccination, and you saw in one of his data figures where their HPV vaccination rates for New York City were quite high compared to the rest of the US. And then you saw that line in between for the rest of New York State. Well, because New York is not just New York City, right? There's a whole other part of the state. And there are very many rural parts of the state, including the North Country, Lewis County and Jefferson County and Northern New York, which have historically low rates of HPV vaccination. So what may work in the city may or may not work in these more rural areas. And so this is why we have to attend to these heterogeneous characteristics of people living in rural communities. And I want to take just a few more minutes to kind of take a look at some of the data we have on HPV cancer prevention in rural communities before transitioning to the importance of those collaborations. Next slide, please. So now I'll move into the data. Next slide. So our program at St. Jude has recently been working with Dr. Jason Semprini and Dr. Whitney Zond on revisiting a publication that Dr. Zond had a few years ago that examined the differences between HPV cancers in rural and urban communities. And you can see here by taking a look at these lines that the gap has increased over time when examining HPV cancers. And the blue lines are HPV cancers in females, and the yellow or goldish, orangish colored lines are among males. And you can see the gap has continued to widen. Next slide. And perhaps what is most alarming when we look at these data points is that about 20 years ago, they were equivalent. That means the rates of HPV cancers in rural communities in comparison to more urban areas were the same. And so we are seeing this widening gap. And so it's really emphasizing the importance and urgency of our efforts to address these differences. Next slide. And so here we can take a look across two of the cancers to see how the gap is widening for female or people with a cervix, and also then males and OPC or oropharyngeal cancers. We can see how these are changes where we're seeing these increasing gaps in rural areas as well. All right, next slide. And not shown here, by the way, due to time, is our intersectional analysis, which has showed how greater disparities among people who, for example, identify as Black or African American and also live in a rural area, as well as for people who identify as American Indian or Alaska Native and live in a rural area, and how they're affected. But you can see here that we've seen over time increasing incidence. And from 2020 to 2021, rural HPV cancer incidence increased by 18%. So this can be a product of many of the influences of the pandemic as well. But what's concerning is over time, the escalation of that trajectory. Next slide. And when we look at mortality rates, we also see that rural HPV cancer mortality is the highest. Next slide. So some key takeaway points here is that HPV cancers are higher in non-metropolitan or rural areas compared to urban areas. These improvements that we've seen in other areas and nationally have been slower for cervical cancer, and we're seeing a deeper pattern to accelerations in oropharyngeal cancers too. Next slide. And so I wanted to take a moment to also examine a look at HPV vaccination coverage in rural areas over this period of time of 2018 to 2022. And we clearly see 10 percentage points differences between people living in rural areas and people living in urban areas. And vaccination coverage over time has consistently been lower for adolescents living in rural areas. And so while these deficits remain, we have been seeing some increases over time for people living, for rural adolescents at the same rate as for urban adolescents here. And so just as a reminder, nationally for HPV vaccination initiation, national coverage, it's about 77%, ranging from about 60 to 93%. And for HPV up to date, it's about 61%, ranging from about 33% to 80% as well. Next slide. So now let's talk about what we do about that. Just talking about the data isn't going to get it done. Nobody marches because of a pie chart or a bar graph, and I understand that. And so now we want to talk about the work that's been being done to act to improve HPV vaccination coverage. Next slide. So the American Cancer Society and the American Cancer Society National HPV Vaccination Roundtable have also been doing work here. And so this is a prime example. And yesterday in the meeting, we heard the evidence summaries referenced. And so the rural disparities evidence summary is currently being updated to make sure that any developments in our research, the evidence base, is able to be integrated in our description about what we know, where are we now, and what's next ultimately. And so the Rural Advisory Committee has been working on updating this, but it's an important tool. It's an easy to grasp tool, and it's one that really becomes a conversation starter when we are getting people to care about why we should focus on HPV cancer prevention in rural communities. Next slide. And you'll have a chance to hear from Ashley Locke shortly in our discussion panel, but she and ACS colleagues have been working on regaining ground in HPV vaccination due to losses during the COVID-19 pandemic, and really focusing on embracing the characteristics and strengths in rural communities through this really impactful rural HPV vaccination learning community approach. And so they have been conducting this starting earlier this year, and they've been able to engage with hundreds of organizations across 42 states who are serving rural communities. And many of these folks who are joining the learning community sessions, they very much want tools. They want help. They want to know how they can do better to improve, to build confidence in HPV vaccinations in their rural communities, how they can share information that will resonate and be effective, and how they can ultimately increase HPV vaccination today. So this employed evidence-based approaches and strategies, including emphasizing different tools that currently exist. We've heard a little bit about the importance of starting HPV vaccination at age 9. That's acknowledged as a really important approach when working with rural communities, because the contacts that someone living in a rural community may have with the opportunity for HPV vaccination may be more limited than in an urban setting, just as one example. Next slide. And also Hannah Nine and Ashley Locke and other colleagues have been working on the Mountain West HPV project, which really has employed a lot of creative approaches, really teaching providers serving this Mountain West area, which is very rural and actually categorized as rural and frontier in many instances, by employing the building and development of a regional consortium of key thought leaders, subject matter experts, and those who are serving these communities, using quality improvement approaches, and then lastly, offering professional education Oftentimes providers serving rural communities are really just the single person serving a large group of people who, again, are very diverse, and they're trying to do their best, and HPV vaccination may not be the most pressing need at that moment in time for the health and well-being of the patient or the community. And so bringing up to speed people who are in these spaces and can serve to help build awareness, share information, and then have people be ready for HPV vaccination is a very important strategy as well. Next slide. And so through our St. Jude program, we convened an introductory meeting. So this was in January of 23, where we brought together hundreds of people doing work in rural health, rural cancer prevention and control, just with rural communities, any connection to rural, and also people doing vaccinations, people doing cancer control, but maybe not necessarily in rural areas. To have this focus on how can we identify key leverage points for us to be able to improve these indicators in vaccination and also downstream in those HPV cancers. And so the goal was really to share information at this point. Then we convened a think tank. So this was a smaller group of experts who were brought together to help generate action steps and prioritize those action steps for how we can today improve HPV vaccination coverage with rural communities. Next slide. And so here are those 6 action steps that were informed by the rural think tank. And so in our commitment to be acting on these, we've worked with ACS, we've worked with the National Roundtable, with AAP and other partners, and you can join our next quarterly meeting update, which is happening on National Rural Health Day, which is November 21st this year. And these focus on starting at age 9, which again, we've heard about, taking advantage of existing resources. We have found that people serving rural communities often can't find educational materials or resources that really attend to the characteristics of those they're serving. So how can we compile those so that people don't have to reinvent the messages and resources, and we can facilitate the sharing of these? Training providers, we heard that that's also been a focus in rural areas and rural communities to build the capacity of healthcare providers and professionals. Advocacy and policy, and while I don't have time to get into this today, I'll give you an example of why this matters in particular for rural communities. Family physicians who are most often serving rural communities and providing high quality frontline healthcare to them, they are reimbursed at lower rates than other provider types for providing HPV vaccination. So this becomes a cascade effect where a health system may choose for the family physician not to stock HPV vaccination, creating further gaps and fragmentation in their recommendation to a family and then the family's ability to access HPV vaccination. So there are several other examples of advocacy and policy needs that need to be addressed to level the playing field structurally for HPV vaccination. Communication campaigns and messaging. We the People Vax is a great example of embracing a lot of the prevalent beliefs that exist across rural America. Now, these aren't the same everywhere, but if your community is one that shares these belief systems, those types of communication methods are important. And we're working on the St. Jude side to develop a menu of message options for rural communities. And lastly, you already heard some of our data highlights. So this leads me to I've highlighted some of the work from ACS, from the National Roundtable and our St. Jude HPV program. In addition, the American Academy of Pediatrics has really been focusing on rural vaccination. By the way, the CDC has a new Office of Rural Health that they've been focusing on rural vaccination too. The AAP has really emphasized the importance of sharing information and building confidence through trusted messengers in rural communities by working with social media influencers. You'll have a chance to hear from Sarah Lawley in just a couple of minutes. And so while these efforts focused on HPV vaccination with rural communities have been underway, we started having conversations about a more permanent organizational structure for all of us who are interested in this area. And so that's really how we came together, because we operate on the principle that collective power is more effective in driving change than individual actions. Next slide. And so various roundtables, coalitions, and collaborations have and continue to build diverse organizational and individual membership to develop and implement these shared strategic initiatives to achieve measurable goals and objectives related to HPV vaccination with rural communities. And the establishment of such collaborations at local, statewide, regional, and even national levels, like we're talking about now, is going to help close these gaps, expand coverage and resources, build capacity among providers and healthcare professionals, build vaccine confidence. And if we're able to change rural HPV vaccination rates and these indicators, this work will ultimately be done with those who have lived experience. So those in rural communities, living in those communities, serving those communities, and subject matter expertise. That's really how we'll truly realize the power that underlies these collaborations for us to bring our collective expertise and experience and identify and implement solutions. Next slide. So thank you very much. Now look forward to our panel discussion.
Thank you, Dr. Brandt. I'd now like to welcome Ashley and Sarah alongside Dr. Brandt for our Q&A. I'm really excited about this conversation. Rural spaces are near and dear to my heart since Indiana has a lot of them, and I live in a rural community, so I'm really excited to hear about the conversations people are having in rural spaces. So first up, I think just a little clarification from all of you about what rural means to you. So let's start with, we'll start with Dr. Brandt, since I'll give Ashley and Sarah a few minutes to get adjusted.
So sure. So at one time, there were more than 100 definitions online about what defines rural. And the official definition that gets used most often is an area of less than 50,000 people where they come together. Now, I grew up in a town of fewer than 1,000 people in rural northeastern Iowa. That picture on my last slide was my dad during harvest last year. And so I would say there's a huge difference between 1,000 people in a town and a town of nearly 50,000, but that really is the definition. And so I tend to follow that definition because it allows for us to examine commonalities on the barriers and facilitators that exist, and also take inventory of the incredible strengths and assets that are prevalent in rural communities too.
Thank you. Ashley?
Yeah, so when I think of rural, I think of the 57 million Americans, including 4 million adolescents who call, rural communities home. These individuals experience many barriers, like Dr. Brandt had shared, including access to care. They have lower health literacy. There's workforce shortages, low-income households, and they have, lower health insurance coverage, which leads them to poor health outcomes, including those higher incidence of HPV-related cancers. And obviously, historically, rural communities do lag behind when it comes to the HPV vaccination uptake. And so, that's why we at the American Cancer Society and the National HPV Vaccination Roundtable, have put together that rural HPV vaccination learning community so we can really start to focus conversations and share best practices around increasing HPV vaccinations in those communities.
Thank you. And Sarah, what does rural mean to you?
Yeah, so I agree with both Dr. Brandt and Ashley. I think the definition of rural is something that AAP has really internally in our discussions, we're always discussing how to best define it and how to apply that to our work. But I think we also tend to stick with the under 50,000 population sort of definition, but also try to, in our work and in our programs that target rural communities, try to be as flexible as possible, because of course they're not all the same, and the case could certainly be made for some populations with more than that amount of people living in the area, that they still have many of the characteristics of a rural area.
Perfect. Thank you. Yeah, my kids go to a school of 400 in the high school. So in our county, we're like the big school. So I understand there's a lot of variations in kind of the way people feel and behave in rural spaces. And Ashley, you kind of mentioned at a high level some of the barriers to care in rural spaces. Can you guys elaborate kind of on what barriers you're seeing in rural areas and what the opportunities or innovations might be in that space as well?
Yeah, for sure. So the biggest barriers that come to mind for me are, access issues and vaccine hesitancy. So when I say access, I mean longer distance to providers, which leads to transportation concerns, costs. And then we also have found, some of our partners working in rural communities that they only have, maybe one provider in, in a certain county or in a certain area. And so staffing, is an issue, which leads to longer wait times, less appointments available, and so much more. And then when you think about vaccine hesitancy, it's not necessarily unique to rural because you'll find parents everywhere, even in urban settings. But I will say that, one bad story or one bad incident in a rural community can spread like wildfire because the community is so small and everyone is so connected. In fact, I'm remembering a story I had a provider once share with me. An adolescent had an unrelated health issue arise right after getting the HPV vaccine, and almost a decade later, she was still seeing families who were saying they wouldn't, vaccinate their child with the HPV vaccine because of that one patient. So, that one story in that community was so detrimental. And so how do you overcome that? And I will say, though, that there's so much innovation and so much opportunity when it comes to rural communities. We have seen when it comes to like access issues and reducing those barriers, we have partners who will implement transportation vouchers. They'll offer vaccines at sport clinics. They'll partner with local pharmacies. They'll incorporate their dental providers and urgent cares, to help create more access. We see mobile clinics, and we even see, EMS providers giving vaccines in communities. So I think, rural has a lot of opportunity, and they can really think outside the box, and it allows for so many more professionals, both traditional and non-traditional, to really, be a part of the conversation and be a part of that uptake.
Thank you. Going back to all those collaborations that we just heard about from New York, right? Dr. Brandt, did you have any kind of barriers that you see in these rural spaces and any innovation and helping reduce those?
So I think Ashley really addressed the major barriers, including, geographic and socioeconomic barriers to accessing preventive healthcare services overall. And so she then also discussed some of the solutions to that, thinking about using sports clinics for physicals, EMS administering those. Also, mobile units have become a really important tool in rural communities. In South Carolina, for example, through the Hollings Cancer Center, they've successfully launched a mobile unit where they go deliver education in rural areas, and then they bring the vaccines along with them. So they offer that type of combination of let's address some of these awareness and education gaps, which do exist, and then let's bring the vaccines back to address some of these access barriers. So those would be one. One we probably aren't going to be able to dig into or solve today is that there certainly are cultural, religious, and/or political views that exist in rural communities, especially during and following the COVID-19 pandemic. I think one of the most disturbing trends that we see in rural HPV cancers is how 20 years ago, rural and urban rates were the same. And so 20 years later, we see that separation. And so that really requires our attention. And so we have to take on those views. And I think that's what We the People Vax is doing with their emphasis on patriotism and, really it's your decision, but you're being a patriot if you choose vaccination, just like George Washington did with the smallpox inoculation all those years ago. So I think there are a lot of creative approaches being employed to align messaging with those belief systems that are so prevalent.
Thank you. I'm going to move on to a couple of questions in chat since we are short on time, and then maybe get back to some of our other ones. But have there been any indication of any other factors aside from HPV immunization as to why the amount of cancer has seen such a separation between rural and urban?
Well,
I'll give that to you, Dr. Brandt.
Oh, sure. Sorry. So vaccination is going to be one piece of this, but we're not really seeing the effects of that yet because that's a downstream factor, right? It's the immediate access to cervical cancer screening and follow-up care. It's the immediate access to dental care, dental practices. It's those types of access to care, proximal places that are really resulting in later stage at diagnosis. And then there have been previous studies about the importance of when diagnosed with cervical cancer, even if you ultimately are treated closer to home, living in a rural area, seeing a specialist. And when you map out where specialists are located, so where those gynecologic oncologists are located, they're not located in rural communities. And so there's that factor as well. And so there's proximity and there's just myriad access to care challenges that are likely the most important indicators of why we've seen that separation over time. And again, it's not just going to be one factor, it's likely multiple factors that have really worked against retaining those similar level over time.
Right. And as our rural hospitals continue to close, I don't see that getting any better anytime soon. So, but I know lots of collaborations and partnerships will help. But the next question is there any data on people getting HPV related cancer after being immunized against HPV?
So that's going to be a question that's probably much broader than just talking about people living in rural areas. So we know that the vaccination that's been available in the United States for almost the last 10 years, so that's Gardasil 9, protects against 9 types of HPV. 7 of those are high-risk types. 2 of those are low-risk types. The 7 high-risk types that are included in Gardasil 9, it's not by accident that those 7 types are chosen. It's those 7 types are the most prevalent. Now, there are more than 100 plus types of HPV and probably about 40 or so that are high-risk types. And so the vaccine only protects against 7. Now, those are the most common again. So it is possible that someone may have been vaccinated, but I'm not aware of any studies that have definitive data on that for someone who was fully vaccinated, especially on time by their 13th birthday, to be afforded the most robust immunogenic response and having full protection. However, we know there are more than just those 7 types, but those are quite rare. What we do know is that people are being diagnosed with HPV cancers, most commonly types 16 and 18, which are included in the vaccine. And those types are preventable with the first iteration of Gardasil and Gardasil 9. So we do know those work extremely well. The vaccine has very, very high efficacy. So that means in a single individual, the likelihood of a robust immune response is very, very high. It's more than 95%. So in an individual, it's most of the time 97, 98% is what we see. So there's a strong response. It works really well. It has, as what we know from earlier in the week from Dr. Staris, talking about the duration of protection and maintaining immunity over time. Also a very strong vaccine in that regard too. It's an amazing cancer prevention tool. And I wish people could just really understand what a gift it is. And you guys heard from Tamika Felder, we heard from Tamika and other survivors. And I mean, ask anyone who's had an abnormal pap, anyone who's had an HPV cancer. This is a vaccination that could have almost assuredly prevented their cancer. That's not a blaming statement in any way. It's just acknowledging the fact of what a gift this is, that someone else we know, love, our neighbors, do not have to suffer.
Thank you. We can feel your passion coming through the webinar. I think a lot of us share this passion for making sure we're protecting all of our young people against HPV-related cancers in both rural and urban settings. But this is such an important conversation. We don't have nearly enough time to have it, so I hope that you all will put in the chat some ways that people can continue this conversation. I know there's a lot of webinars and opportunities for people to continue thinking and talking about rural spaces. So please put that in the chat for our participants to look at. I am going to thank you all for being on the panel and turn it back over to Christina to close out our party here today.
Yeah, thanks, Lisa. And thank you to everyone today who presented, Dr. Kristen Oliver for kicking us off for this amazing party we've had today. I could really feel the passion there at the end with Heather talking about how this is a gift. And if we could really talk about that cancer prevention piece, that's why we're all here and that's what we're passionate about. And I hope today you were inspired to partner, to collaborate, to keep pushing this work forward. Next slide. I just wanted to give a few resources today for our after party. You heard this referenced in Dr. Brandt's presentation, but we do have our rural HPV vaccination learning community, and you can see the information on that here. We have a landing page for it that is in the chat. There on the landing page, you can see all the past webinars as well as registration for future ones. We also are very excited to roll out our updated cancer prevention through HPV vaccination action guides. We have one for health plans that was rolled out earlier this year, and these are the updated, I think we have 5 that have been updated for large health systems, small private practices, nurses, medical assistants, physicians, etc. We are still working on the dental action guide, and that will be coming out later this year. Next slide. We also have our HPV vaccination best practice sessions, and we have one more coming up on November 20th, but the past recordings are all available on our website to view, and you can register as well for the November 20th session. Next slide. And then we also wanted to talk about the 2025 National HPV Conference that is hosted by the Indiana Immunization Coalition. And so you can find more information on that as well, or visit nhpvc.org for registration and more information on that conference. Next slide. And then we are celebrating this week, and we would be remiss not to celebrate our amazing steering committee and co-chairs. Many of these people you have seen and heard from throughout the week, but they are a driving force of passion, of innovation, of pushing this work forward. So a huge thank you to our steering committee and co-chairs. Next slide. We do have a session evaluation. It is brief. You can take it here, and I believe it'll also come up as you close out this session to take as well. And the link is also in the chat. Last slide. And the party continues tomorrow. Dr. Heather Brandt will be back leading our session tomorrow for global best practices in HPV vaccination. And it's our final day of this awesome celebration we've had all week. So I hope you can join us as well tomorrow, same time, same place. And thank you, everyone. HPV vaccination is cancer prevention, and we're looking forward to seeing you all tomorrow.